Director of Pharmacogenomics in the Center for Molecular Medicine. Mark also, besides implementing all of North Shore pharmacogenomics, has also been very active in CPIC. He has been a co-author on several of the CPIC guidelines, which for you who don't know, the CPIC guidelines are those guidelines that provide recommendations on what to do, the action that would be taken in a patient in terms of if they had pharmacogenomic information. Mark is very well known for his efforts in pharmacogenomics and particularly his very successful efforts at North Shore in implementing pharmacogenomics there. Mark tells me that, you know, his job has changed some, and they really now have used pharmacogenomics as a launching point to implement a whole lot of precision medicine. So moving into disease genomics and other things, so well beyond pharmacogenomics. So I think Mark's work at North Shore is an absolute example of a success of precision medicine, and so we're really privileged to have him here today. So join me in welcoming Dr. Dunnenberger here today.
Well, thanks everybody. Sounds like I'm mic'd up, so we're good there. Pam, thanks for the great introduction and the invitation to spend a couple of days here in the Twin Cities. I've got to meet with a number of people. We have a great group here trying to implement precision medicine across the state of Minnesota, and I wish you guys great luck on that process. For the presentation today, I'm going to walk you through the journey that we've taken at North Shore to bring precision medicine. At North Shore, we prefer the terms personalized medicine to the front lines of care. How in a community health system can we ensure that every patient who can benefit from personalized medicine has the opportunity to benefit from personalized medicine? That's really our mission, and that's what we're trying to do on a day-to-day basis. Objectives for this lecture: after this, you should be able to describe some of the barriers to genetic implementation. You should be able to list the components that it's going to take to do personalized medicine, and then hopefully you'll be able to describe a process, I didn't say the process, but a process for implementing genomics into primary care. And I say a process because it's the North Shore way. It doesn't have to be your way, but there are probably some things that you can take away from it. So what is North Shore? It's a community health system serving the northern suburbs of Chicago. So think about Wrigley Field, going all the way up north to the Wisconsin border and stopping there, and headed out westward from the lake. It doesn't quite get to O'Hare, but getting pretty close at this point. We have a large medical group of over 100 offices, 4 hospitals. I need to update the slide. In the last month, we've bought a 5th hospital, which brings us a little bit closer into the city. You can see our numbers with admissions and ED visits. So we're a medium-sized hospital as far as I'm concerned. And one of the keys to our personalized medicine is an integrated EHR. So what this means is when I develop an informatics support system, it works across the whole system, inpatient and outpatient. I'm not having to do duplicate build, and that's been incredibly powerful and allowed us to do a lot of things very, very quickly. Talk to you a little bit about what North Shore looks like, but what are the realities when we think about genomics care at North Shore? So one, and this is probably the most important one, there's an emerging demand for genetic services with our population. So we're not out there trying to convince people you need to do genomics. Instead, we have people coming to us saying, I want to do genomics, I want to use genomics in my care. And we're faced with the challenge of how do we scale and meet that need across our whole geography? We've had a Center for Medical Genetics for a while. This is one building, one clinic, one office. It has some built-in infrastructure to handle really challenging cases, so that's great. We're beginning to create a support network by having the Center for Medical Genetics. It allows us to have some expertise to develop workflows and understand, well, if I could put all of the people power into it, what would it look like? Because we have a really targeted group there. But because it's really targeted, we have a limited capacity. But we could think, if we can deliver genomics in this one particular specialty clinic, why does it have to be the Center for Medical Genetics that has that specialty? Why could it not be a cardiology clinic with a cardiologist who's interested in genomics delivering that? Why could it not be an oncology clinic neurology, right? You just start naming the specialties. And why could we not take genomics and put it in there? There's nothing really unique about the Center for Medical Genetics, except it has a medical geneticist in there. That's really it. So how do we take this model and expand it across all of our specialties? And so we have the vision of bringing genomics to the front lines of care. Specialty clinics launched across a broader system-wide initiative. We want to create a large center, and we're going to make it a virtual center that links all of these things together. So we're using the same tools where possible and building off the successes of one implementation to help with the next. We know we had to create, and we continue to create, seamless workflows that make it so that the frontline practitioners and the patients are doing clinical care that includes genomics and not clinical care that has the added to of genomics. It's not additional work that you have to do. It's just taking care of your patient with the best information that you have possible. And while we do that, we've got to bring education along. And education has to be a huge piece of it. But it's got to be consistent across the health system so that at the end of the day, whether you see a physician in the far northwest corner of our health system or the far southeast corner of the health system, if you have a genetic variant and the same genetic variant with everything else being considered, you're treated the same way. We don't want to create some kind of disparity across our geographies. We need to make sure everybody's educated in a consistent way, and we develop a system that allows that to happen easily. It makes it really hard for that not to happen. So great aspirations. What are the challenges that you face in primary care to try to do this? Well, time is precious. Part of it is education. How do you get a physician to sit down and listen to an hour-long lecture? Maybe in an academic center, you might be able to pull it off, but in a community health system where RVUs are what drives the clinician action, why are they going to give me an hour? The answer is they're not. So I've got to look at developing the education that meets the amount of time that they have, and how do I integrate it into their practice where they need the education to do their job, it's not an added to. How do we break down genomics in a way that you can do it in the amount of an appointment that you have? You're with a patient for 15 minutes. How do you have a discussion that in the Center for Medical Genetics takes 2 hours, and it's the only thing you're talking about? You're not talking about their hypertension. You're not talking about your diabetes. How do you handle that inside of a primary care clinic? It's a tough balance. Time is precious. We have competing guidelines and competing initiatives. Personalized medicine isn't the only thing that we're trying to do new and innovative at North Shore. How do we get people's attention? How do we make this happen? Then we have competing guidelines. If you think about colorectal cancers, all of those guidelines don't have the same screening recommendations. So maybe this group of physicians want to believe this guideline and this group wants to believe this guideline. If we're trying to create a uniform experience for our patients across the health system, who's right? We don't know yet. We're trying to figure out how you do that. And then there's myths and realities. We said there was a growing demand at North Shore to do genomics, but not everybody wants to do it. And so they hide in these myths to say, well, test costs are too expensive. There's absolutely no reason why we should do this. Well, if it made sense to do it, insurances would reimburse for it. So we'll just wait for them to get it done. Maybe we can't wait. Maybe we're missing opportunities to improve our patients' health outcomes with genomics. And if we wait for the insurance to come on board, we're going to impair people's health care. And then a lot of people are concerned about non-discrimination with genetic data, and they don't understand the laws that are in place to protect people, like GINA, or the Genomic Information Non-Discrimination Act. And then, again, how do you bring all of this together so that we get this seamless experience across the health system? And we're going to do that with EMR integration. And the EMRs aren't natively built to handle this type of thing. You've got to be willing to get in there and break it, try something, get it wrong, go back and do an iterative process, fix it, and make it the right way. Get it out in people's hands and understand what they need. What does it take to get this done? And EMR integration is key to getting that done. So great barriers, talked about challenges there. When we break down the personalized medicine program, we think about it in 5 components. Some of you guys saw a slide very similar to this yesterday that said the components of a pharmacogenomics program. You're going to see a lot of that again. You can reuse the tools that you develop for one program for another program. So if you're thinking about personalized medicine, you have to have genetic testing. Otherwise, what are you going to talk about? You have to do education. We kind of talked about that already. And then you have to have informatics support, which is what's represented in the blue here, to get that done. It's going to be about genetic results. If we implement genetics across the health system and we have 5 or 6 different labs, they may report the results in 5 or 6 different ways. How do you integrate that all together so that you get a consistent flow and a consistent representation of that data? So that you don't have to teach physicians that these 7 things all mean the same thing. That really just ramps up your educational needs. So if we can get it to look the same, then we only have to teach them how to use that one thing. You've got to take this data, because at the end of the day, that's what a genetic result is, and combine it with some knowledge so that it becomes actionable information. You need to do that with some process. CDS, clinical decision support, is probably the best way to do it. Once you have the data and you have the knowledge, you put them together, deliver them in a meaningful way, represented here as a graphical user interface. We typically think about that as the EHR or the chart, but maybe that's not the only place that we do it, especially as we think about how do you make this happen for patients? How do you engage the patient outside of the walls of your healthcare system? Their health doesn't stop at your door. Their health is what they do every day. They live with their genomics. Why don't you bring this data to them to change their everyday life? Take healthcare outside of your walls. Genomics is new, so people expect it to be different. Take advantage of that to revolutionize your model of healthcare. It's been a journey at North Shore. It's not something that we decided to do and then the next day we did it. The details of this, not too important, but what's most notable is it's been over a 20-year journey. And it started with the laboratories. In 1997, we started the Center for Medical Genetics. The fun trivia fact is Henry Lynch of Lynch syndrome helped us start that. We had the Center for Molecular Biology and Molecular Medicine in 2012. 2014, I came on board and we really started doing pharmacogenomics. And then we continued to grow from there. And I'm going to end this presentation with our newest initiative, the DNA 10K project, which is bringing population screening to 10,000 patients in the primary care setting. So what does our Center for Personalized Medicine look like? Well, it's a virtual center, so you can't go to our campus and find a building that says Center for Personalized Medicine. This virtual center, the goal is bringing genomics to clinical care. It's not about doing research. It's about saying, hey, there are a lot of people that have done a lot of really great research, and genomics is ready for prime time. Let's put it out there in the wild and see how it works, see what problems we have. So to do that, we have a pillar for molecular pathology. We have some expertise at North Shore to do testing. We do a variety of different tests. It's nice to have, it's not a requirement, but it allows us to be pretty flexible. We've kind of already talked about the specialty clinics. This allows us to have a support network so that if we have genomic data and somebody has a question, there's an expert to go to, and you can even refer your patient there. You can talk to your patient, you can call the clinics, or they can actually go there and see that particular expert. We've kind of started with the Center for Medical Genetics and grown from there. We have systematic integration of the data so that you get that uniform care across the system. I've hit on education several times. I'm going to continue to hit on it. It's key to getting this done, and it's education in real time in clinical care, because unfortunately, medical schools, pharmacy schools haven't quite caught up with teaching people this type of information yet. I said we're focused on clinical care, but we do research as well, and a lot of it is clinical research of implementation science. So we did this. Did it work? How can we make it better? How can people learn from our lessons? It's one of our pillars, but it is not the primary pillar of what we do in the Center for Personalized Medicine, and that's what makes North Shore unique in this space. We talked a little bit about the EHR integration and talked about standardizing the data, and the North Shore genomic data flow is one of the key pieces that we put together that enables us to do a lot of different things. So we have the electronic medical record. We've interfaced with internal and external laboratories. We put it into FLIPE, this genomic repository, That allows us to standardize the data. It allows us to hook one pipe in and out of Epic. We're able to go out to DB-SNP, ClinGen, Cosmic, all these other knowledge bases. We contain our own pharmacogenomic knowledge base, and we can bring it all together and then deliver it back to the clinician in a really impactful and useful way. And we're working on challenges of how do you do that to the patient. What does the patient need to know, and when do they need to know it to change their behaviors? At the end of the day, doing personalized medicine is going to require the patient to do something they didn't do in the past. In pharmacogenomics, it may be taking the right medication, but more importantly, it's taking the medication that was prescribed to them. For a patient who has a family history of cardiovascular risk, how do you use the genomic data to adhere to that diet recommendation that you made as a physician, that exercise recommendation? You're making the patient do something different that they may not have been motivated to do before in the past. Take that example and apply it to any other disease state that you might see fit or that you practice in. How do you deliver that data to the patient? How do you activate them? We've started a journey. I showed you a chart that started in 1995 and has moved on since then. Since I've come on board in 2014, we've started on really targeted implementation strategies, one project at a time, and from that project, grow to the next project. Take the lessons that you learned. What did you do well? What did you do really bad? And let that inform your next project, and your next project, and your next project, so that you're not reinventing the wheel every time, because this is all personalized medicine. It should have similar foundation and structure. So we're going to walk through these particular strategies. Spend a lot of time on pharmacogenomics. That's my area of expertise. That's what gets me up in the morning. That's making me excited to go to work. And then we'll talk about our family history tool. We'll talk about our population screening. I'm not going to talk about polygenic risk scores. We're not quite there yet, but that's where we're headed to, and that's the future that we're looking at. So for pharmacogenomics, take a minute to thank everybody that I work with. These are all the people that make everything that you're about to see possible. Without them, I wouldn't be able to do anything. We wouldn't have a successful program without all of these people. So take a minute to thank them. But you might know one or two of these people. I think what might be more impactful for you is, what are their professions? This is a multidisciplinary team. We talk about that all the time. Medicine is multidisciplinary. Personalized medicine is definitely multidisciplinary. Without each of these professions represented, without each of these people's specialties there, we would not be successful. And we're covering the gamut. We have physicians, we have senior leadership administrators supporting us through this, actively involved in the process, so we can establish a business case that's aligned with the healthcare system, so that they will continue to support us and we grow with them and get where the healthcare system needs to be. Personalized medicine, pharmacogenomics, is pushing the healthcare system forward, revolutionizing care at North Shore, not being reactionary, not waiting for it to come to us. Bioinformaticians are helping us with this data, turn it into information so that we can turn it into knowledge. Got to have our pathologists, genetic counselors, nurses, pharmacists. We all play a huge role in getting this done, because we're touching every fabric of the healthcare space and the healthcare process with pharmacogenomics and genomic data now. Apparently I love timelines, so this is our second one of the presentation. It starts before I got there, pre-2014. For pharmacogenomics, this is the wild, wild west. We know people are doing stuff with pharmacogenomics, but we have no idea what it is. Occasionally somebody shows up with a report. They can't even tell you how they got the report, but they have it and you got to use it. No idea why they got it, where it came from. Has it been used already? Have we already tailored their profile? We don't know what they did. They don't know what happened. It was really the wild, wild west. Within the first month of me getting there, we were able to get some structure in place. All of that previous work that they had done starting in 1995 set up the framework so that I started on August 4th, and by the end of August, we had a governance committee. We had a clear chain of command. It was done. It was in place. Now we can start to do work. We have a team together. We have a focus goal. Let's set out and accomplish the tasks that we need to accomplish. One of those early tasks, represented here in January 2015, was understanding, what does it take to do genomic clinical decision support in our medical record? There was a temptation to pick One of the biggest drug gene pairs out there. So at the time, you might think clopidogrel and 2C19. We're talking about saving patients' lives by changing their antiplatelet agent. Sounds great. We looked at our drug usage. It was used all over the place in our healthcare system. With one drug gene pair, we can impact thousands of patients a year. With one drug gene pair, the flip side of that is we could tank pharmacogenomics across the healthcare system. If we did this one implementation wrong, it would taint the soil for a while. So that home run wasn't the best choice to start with. Instead, we looked at something that was a little more targeted, somewhere we had physician engagement at a stronger setting, and that was TPMT and the thiopurines. We had a group that was engaged. Why were they engaged? Well, it just happened to be that the department head for rheumatology, which is our most common user of this medication, went to college with the lead medical geneticist that we had. So they were friends. It was that personal connection that allowed us to move into that arena first and try to solve a problem they had, which is who has a genetic result and who doesn't. We were solving a clinical problem for them, using personal relationships to drive precision medicine forward. We also picked a few other ones because we felt like it was just bad standard of care if we didn't do it. So HLAs and abacavir, HLAs and carbamazepine. We wanted to get enough variety in there that we had a chance to prove a concept. Pick targeted drug gene pairs. We did it. We got some things right, we got some things wrong, but we got immediate feedback, made some changes, and then most importantly, and you guys have all heard this in any type of quality assurance presentation you've been to, closing that feedback loop, going back to those physicians and saying, with your input, here are the changes that we made, keep working with us as we move forward, and together we will continue to make this better and improve the outcomes of our patients. So we got that up and running. We continue to have a demand to do pharmacogenomics and do broad-based panels. And so we started a pharmacogenomics clinic in March of 2015. And now we have the longest running clinic of its type in the country. And that is a multidisciplinary clinic dedicated only to pharmacogenomics. So if you're a clinician at North Shore, you want to use pharmacogenomics, you don't know what it means to do that, you can send your patient to our office, we'll sit down, we'll counsel them about it, we'll return their results to them, we'll integrate them in the medical record, and we're there to be your ally and your support as you utilize those throughout that patient's lifetime with you. In 2015, we used third-party testing because our pathology lab wasn't up and running on a genomics platform yet. You can see about a year later, a year and a half later, in October 2016, we started with our own in-house panel. So we've had experience doing both, pluses and minuses depending on your particular expertise. In March of 2016, to better integrate and ensure that we have that continuity of care across the healthcare system, we partnered with a third party to develop clinical decision support for more than just the 3 drug gene pairs we started with. And immediately we had 9 genes integrated with 45 drugs. And that was just because we turned on their knowledge base. Really ramped up our impact. Had the in-house testing. I had a wait time for my clinic of 8 to 9 weeks. Not the best way to wait for a test that then takes 2 weeks and you have a clinical decision waiting. Can you really delay therapy for 10 weeks for a patient who's depressed? Probably not. So we created a process in the medical record where any clinician at North Shore could order pharmacogenomics. The patient would go home and watch a video. That was the pre-test counseling. At the end of the video, they'd put in their address. We'd send a buccal swab kit to their house. They would, in theory, send that back to us, and we'd do the testing. You don't always get the kit back. You don't always get the patient to the educational video. We had to pivot away from that, and I'll show you what that looks like in a second. And now, in April of this year, we've moved on to this DNA 10K population screening. It's got hereditary cancer, cardiovascular care, and it has a baked-in pharmacogenomics panel. So now we're moving into the space of what we think is the future of personalized medicine. Getting genomic data and then maximizing the value of that genomic data. So this is getting a sequence or genomic data from a patient that has pharmacogenomics embedded in it, and you're pulling it out and maximizing that value. You didn't do it because the patient had a drug problem. You did it because they had a family history risk, or in this case, it was a population screening. Did we have the tools in place? And luckily we have. It's because of all this previous work that we did. Education, told you I'd come to it again. Most people think about education as the clinical content. What is pharmacogenomics? Why is it important? What drug gene pairs do I need to be concerned about? How do I interpret a test? What are the LC issues going on in this space? But what we found out when we're trying to actually do this in healthcare, the most important thing to teach somebody outside of a clinical setting is how to use the tools. How do you use the clinical decision support tool that tells them this is the medication they should use, this is the adjustment that they need. And once we were able to get them to use those tools, we were then able to use those tools to deliver the clinical knowledge with the patient in front of them, with that clinical problem that they were trying to solve. Much more impactful than sitting in a lecture hall listening to me talk to you for an hour. Or doing a webinar and having that playing on the background of a computer while you have a nurse behind you yelling at you. You have your other phone ringing, and it's a pharmacist going to call you about a prescription that you wrote that wasn't quite right. You're not going to get a lot of pickup. So if you can really use those clinical decision support tools to do in-the-moment, bite-sized education, you can tackle the earlier piece. It doesn't have to be in your traditional educational pathway. In addition to teaching people how to use stuff, you're also getting them to use the services that you're creating. So this is our clinic volume map. You can see that there's some peaks along the way over time. And every one of those peaks was preceded by an educational event. It was either a grand rounds, it was a newsletter story that we had in our patient outreach. It was in a news story in a newspaper. There's all kinds of different things, but every one of those led to an increased volume in our utilization of our services, and you continue to see that. Unfortunate side of this is it's not a durable response, so it's not that you just get the peak and it stays there the whole time. It does fall off. So you have to continually educate people in the process, and it's really, really important to do that. So I told you we had to have a transition from that kit that we mailed to people's house, or maybe we didn't even get it mailed to their house. So now we use a buccal swab in the clinic. So if you come in, we don't want to give you a blood draw because we're not drawing any other labs. There's no real clinical reason to stick somebody. So we'll do a buccal swab. But then for any other physician visit, they can order the test. In this case, we're going to talk about PCPs. And because maybe it's your annual physical where you're going to get labs drawn anyway, just stick a lavender top tube on there. No extra stick for the patient. We get all the DNA that we need to do our job. This works out really, really well. We went from about a 30 to 40% completion rate of every test ordered to now about 80%. We even have more tests being ordered now because people are completing it, physicians are getting more exposure to the data, and we're having better outcomes because of that. But it doesn't matter how you collect the sample. It all gets put into the medical record, and it's all delivered with the same clinical decision support. And if you don't understand that clinical decision support that makes that recommendation and tells you what to do, the safety net of the pharmacogenomics team is available to help you out. You can send the patient to the clinic, you can call us, you can email us. In fact, my cell phone's my pager. I could get paged right now if somebody had a question. We're available all the time, and we're a safety net to ensure we're maximizing the value of pharmacogenomic data in our healthcare system. What does our data look like in our EHR? Well, in some cases, it's as simple as the genotype doesn't mean a lot to many people. The pharmacogenomics team's really excited about this, and we understand it, it's great. We take that knowledge, we turn it into phenotypes. We use this phenotypes to drive our clinical decision support. Any clinician can go here and take a gene-centric view of the patient. That little eye that you see on there, you hover over it, and it will tell you what a 2C9 intermediate metabolizer means. In the moment education using a clinical decision support tool. We use those phenotypes to drive our interruptive alerts. You can see here that interruptive alerts are really, really compressed. Tell you what the clinical problem is, tell you how to avoid it. But if you notice, there's an additional information in the blue there. You can click on that and you can get like a 3-minute answer. And it also has another button that you can click on and you can get the 30-minute answer. 30-minute answer includes citations. So if you want to write a dissertation on this drug gene pair, you're on your way and you can do it. So it's a 3-second response, a 30-second response, 3 minutes, 30 minutes. all built in, stacked together, and whatever the clinician wants to go after. It does contain limited genetic data because your average clinician right now probably doesn't care that this patient is heterozygous for STAR2. It doesn't matter to them. They care about the drug they're about to prescribe for the patient. How do they make the change? How do they do the behavior that we need them to do? This is what, 8 words? The feedback that we're currently getting, that's too long. I don't have time to read 8 words. So now we're trying to figure out how you do this in symbols. How do you use colors? How do you use iconography to make this happen? Or can we do it better? Can we get in front of this decision? At this point, the clinician may have already sent the patient out. They may have already told the patient, hey, I'm about to write this prescription for you. Go to the pharmacy and pick it up. They may have told you the name. It's clopidogrel. This patient goes to that pharmacy and says, I'm here to pick up my clopidogrel prescription. The pharmacist looks up their name, and they see a ticagrelor prescription. What does that pharmacist do? Calls the doc up and says, hey, this patient wants clopidogrel, you gave him ticagrelor, why'd you do that? And now they have to remember that they got a pharmacogenomic alert and all this other stuff, right? So maybe we missed the point of biggest impact. Could we have identified that this patient last week had a stent placed, and this is their follow-up visit to figure out what they're going to do, and go ahead and know that the physician's going to give them an antiplatelet agent and tee them up with ticagrelor right away? Could you do it? I can write out the sequence. If I can write out the sequence and I know it's consistent, you can program a computer to do that. It's a little more complicated, but maybe that's where we'll be in the future. How do we get ahead of the clinical decision-making process instead of waiting for the decision to happen and then react to it? One of the ways that we do that at North Shore is a passive CDS. So we do a pharmacogenomics profile on a patient, and then we give physicians access to a drug list that are all the drugs that are a problem for this patient. We don't know why you're seeing this patient, but here's an alphabetized list of all the drugs that they have a pharmacogenomic interaction with. It's no longer gene-related at all. It's all drug-centric, so that's good. The problem is some of these lists can be really, really long. You have a list of 40 drugs, and you're looking for one. You don't see it. Is it not there because you just didn't see it in the alphabetized list? Or is it not there because it's not a problem for the patient? Maybe not the best way to deliver this data, but I think we're getting a little bit closer. We have some ideas on how to improve this, hoping to roll those out in the next little bit. That iterative process, do something, make it better the next time. Get the feedback and make it better. Get the feedback and make it better. You are not going to get this right the first time. It takes an iterative process. Don't be afraid to make a mistake. Just don't make a huge one. Make a mistake that you can fix. So for all those tools, what did we do? Well, in 2015, you're seeing the utilization of the pharmacogenomic services. 21% primary care. Biggest driver is psychiatry. If you're in psychiatry and that's the first time you're being tested, that's not the first time you got an antidepressant. It's probably not the second time you got an antidepressant. We're beginning to lose opportunities to use pharmacogenomics to improve patients' lives. Interesting story about this graph. The 15% in neurology, that's one clinician who had one patient that really benefited from pharmacogenomics, and now he tests every single one of his patients. I don't know if he needs to or not, but he does, and we know because we're doing a multi-gene panel, they're getting some type of valuable information. So that was in 2015. You saw on that timeline all the things we did after that. In 2017, primary care was the driver. So we believe that based on all the work we did and this utilization, we have now taken genomics and put it into the front lines of care. We have primary care docs engaged in genomics. Our first success, our first win. Where do we go after that? That's one more slide. As we think about the value of pharmacogenomics. We talked about all of the testing happening in primary care. These are kind of the volumes of patient visits with patients who have pharmacogenomic data. The green line represents specialty care. The red line represents primary care. The blue and orange line are ED and inpatient visits. What's interesting here is as we look at the impact or possible impact based on patient exposure to the healthcare system, even though we're doing a majority of the testing at the PCP level, that may not be where the biggest value is or the biggest exposure is. It's probably in the specialty clinics. You can see that by the volume. We broke out psych as its own thing. So if you put that on that specialty bar, it's way above primary care. So now as we think about the value, we have testing occurring in one place, but value being derived across the healthcare system. That's why the CDS becomes really important, because now you have clinicians who didn't order the pharmacogenomic test, but can probably benefit from that knowledge that we learned from that data. How do we get them to use it? How do we deliver it to them? And how do we do it when some of these patients got tested in 2015? That was 4 years ago. When was the last lab result that you guys looked at that was 4 years old and still was relevant for your patient? It's a huge challenge. The medical record isn't really set up for that kind of longitudinal tracking. So those are some of the challenges we're tackling right now at North Shore. Value, we kind of talked about where that might be. We're really focused on performance indicators right now, thinking about clinical indicators later. Clinical indicators, you have to have a pretty good either homogeneous population or a large number of patients that have pharmacogenomic data. This will be coming, but if you develop a program, make sure you have a way of measuring success and make sure that's aligned with your mission of why you're doing it. We talked about timing of tests, and for the sake of time, I'm gonna hop over this one. But just know that depending on when you're doing the testing, the value may change over time, and so you need to align your testing mechanisms with your value measures. We had a patient and provider surveys, and we can see that providers think that pharmacogenomics helps in individualized treatments. That's a slam dunk. It can help in mutual decision making, and we can increase patient satisfaction. And that's coming from the providers. They believe that their patients are more satisfied from it. That's pretty exciting. We have some challenges. We know that these challenges are not related to, they are related to pharmacogenomics, but not unique to pharmacogenomics. They're a problem across the healthcare system with any new type of innovation. When we think about the patient satisfaction, we did a survey for patients and we get the same signal. So you can see that a majority of patients are more confident in their prescriptions that are prescribed after they have testing, and they're more likely to take those medications. So now we're getting at an additional signal, a psychological change, a behavior change, that thing that we're trying to get after. Patients, when you take a medication, it's got a chance at working. When you don't take a medication, it has no chance of working. We're using pharmacogenomics, hopefully, to increase that adherence, increase that likelihood that a medication will work for a patient on multiple levels. All right, so hopefully you guys now believe me that we're doing pharmacogenomics in primary care. We're bringing genetics to the front lines of care. And what lessons did we learn there that we can take to the next thing, which is a family history tool. So when we think about testing, one of the approaches is we're going to test people who have a strong family history of likely genetic illness, right? Risk of cancer. Your cancer pattern increases my suspicion that your family has a genetic variant. That's one approach. The other approach is, I don't care what your family history is, I'm just going to test people and see what happens. We know from published data that if you just indiscriminately test a population, you're going to find somewhere between 10 and 15% variance, maybe closer to 10%. It just depends on what you're testing and how deep you're going. Can you enrich that? Can you do a better use of your resources? So with this family history tool, it's 2017, right around that time that we finished up the initial implementation of pharmacogenomics. We created a genetic checklist. So it's 30 yes/no questions that ask you about your family history. It covers cancer, cardiovascular concerns. We ask if you're interested in pharmacogenomics. We also ask if you're interested in a population genetic panel. So kind of, we don't care what your family history is, we're going to test 475 genes and see what happens. Those other ones are really targeted to the specific disease state and the particular family history that you have. We're going to offer the primary care doc in response to this questionnaire and what happens, either a genetic test or a referral to one of those specialty clinics that we set up. So you have a family history that's indicative of a cardiovascular concern. Let's say it's FH, familial hypercholesterolemia. You're going to go to our cardiovascular doc that does cholesterol and lipids and knows a little bit about genetics. And we're going to offer you a panel that's targeted at FH. The clinician can pick which one they want. The idea here is if we test people at the primary care level, then the specialist is seeing the patients with the positive results. So then the specialist's efforts are more targeted. They're not the ones that are screening anymore. We're opening up capacity to test more patients and make genomics available to more patients. Reduce the barrier to entry to using genomics in care. Kind of talked about this earlier. If we're going to do this, it has to integrate into existing workflows. It's not an additional to, it's just a part of clinical care. We can put it in the workflows if we support it with clinical decision support. It has to be patient friendly and it has to be engaging, because the patient, after they do this tool and their doctor orders the referral, they got to go to the referral. They also have to go get the genetic test done. And we learned in the pharmacogenomics world, it's not a one-to-one. Just because the doctor orders the genetic test doesn't mean that it gets done. So we got to engage the patient. And it's education again, and in the moment, and really broad, because now it's not just pharmacogenomics that we're talking about. It's cancer, it's cardiovascular, it's a population screening that covers a lot of different areas. What does that education look like? And we were working on that for a while. Here's the workflow that we had associated with it. So the GWA is this tool, the Genetic and Wellness Assessment. Patients got this in their North Shore Connect, or their online portal for the medical record, 3 days before their primary care annual physical. Go online, fill out the checklist, sits in the logic engine here, it spits out an answer. Not everybody has the online portal. Not everybody's going to spend the time to fill it out ahead of time. So we offered a paper version. So while you're sitting in the office waiting for the physician to see you, you fill out the checklist. The MA puts it in the medical record. It gets you to the logic, deliver the clinical decision support, go get the testing, go to the referral. If you get a positive result, you go back to referral. Pretty easy workflow, pretty seamless. The primary care doc just had to react to the interruptive alert. They didn't have to know that these 7 criteria makes you positive or meeting NCCN criteria for testing. It was all baked in. Reduce our education barriers by using clinical decision support tools. Here's what they look like. At the end, you get 2 options. Genetic test lab order. We didn't even necessarily tell them that this was a cardiovascular test from Invitae or from Ambry or from our internal lab that you're ordering. We just said this is a genetic test that's most appropriate for this patient. And here's a referral that makes sense to send based on their answers. We got a lot of feedback about this. So this kind of goes against principles of clinical decision support. So remember, for the pharmacogenomic thing, I just showed you an 8-word alert. And clinicians said that was too much. There's more than 8 words here, right? They actually said this wasn't enough information. This was version 1 of the alert. I don't have a picture of version 2, but it's even longer and has even more information because they wanted that information in this setting. We could have taken the lessons from pharmacogenomics, applied it here, and it would have been wrong. We had to learn by putting it into practice. Interesting question about why is there the difference between the two? Is it that this might be diagnostic and so they want to know more about it, and pharmacogenomics is about affecting probabilities? We don't know. An interesting research question that we could go tackle in a year or 2. So we operationalize this, and then we need to figure out, does our system work? Who's engaging in it? I don't know what just happened, but we'll solve that. All right, so we have all these dashboards now, and we can tell you where everybody is in the process. Are they answering the questionnaire? What BPAs are firing, or what alerts are firing? Are the patients following up with that? When they get a positive result, what does their downstream care look like? This is all dashboard, and we can get it in the moment, and it's updated every night. We can make real operation decisions based off this data in real time. It's about clinical care. It's about quality improvement. We've got data at our hands. In fact, we can tell you which of our clinicians are most likely to follow our recommendations. We can go out and do targeted education to the group of clinicians that aren't doing what we would like them to do. Find out what's wrong with our tools. Because if they're not doing what we want to do, it's not that they're doing something wrong. We're just not doing our job well enough. We've got to reach them in a new way and activate them in a way they've not been activated before. So it's great to have all this data and have it at our fingertips. You guys couldn't read that data, so you might want to know what's going on. Well, we've had over 100,000 patients fill out the GWA. We've actually had over 200,000 GWAs filled out, but it's been a couple of years and it's at the annual physical, so we can actually track what the patient does every year. We pre-populate the GWA from the year before based off your answers. We tell the doctor that, you know, you referred this patient to high-risk breast cancer last year. They didn't go. Do you want to refer them again? You want to have that conversation? We're really tracking that and delivering it back to the clinician in real time. We've triggered over 50,000 BPAs. This is the real problem that we have. 23% action rate. So BPAs probably aren't the best way to do this. We got to figure out how to do it better. It turns out that if you look at across our system BPA rate, everybody in HIT is actually really excited about this 23% because everybody else is somewhere around 20 or lower. In fact, we have some alerts that don't ever get acted upon. We're getting rid of those as well. So noise signal ratio, we've got to solve that. We did some chart reviews of the first about 500 patients that went through the process and completed the recommendation. And what we found is this tool is working. Instead of seeing about the 10% positive rate that you might see if you just population screen, we're up around 20, 25%. So 20 to 25% of the people that are doing the testing have been found to have a pathogenic variant. This tool works. We're able to use family history questionnaires to enrich our positive rate for genetic testing. But maybe it doesn't work because we're only doing about a quarter of the tests that are out there. Okay, so maybe you got lucky with those particular positives. What else is going on? Will insurance pay for those tests? Well, about 86% of patients meet NCCN criteria for having a high-risk breast, hereditary breast ovarian cancer risk assessment. Our clinicians are doing the appropriate things with this. 78% of them have recommendations of management changes that are in line with the guidelines. And what gets our administration really happy and excited, 31% of patients surveyed gave the perception that their care was significantly better because of this tool being in place. That means something to our physicians and our administrators who are trying to improve patient perceptions of healthcare. Genomics can do that if applied in a useful way. All right, so we had a pretty successful family history tool. Now we went to the population level. Maybe we can just test everybody and that'll solve it. So we had a DNA 1K and a DNA 10K. 1K, 1,000 patients, 10K, 10,000 patients. DNA 10K, we wanted to test 1,000 patients in 2 months. We did that at 4 PCP visits. We turned off the GWA. We turned on this, hey, do you want this test kind of offering? We made it free to the patient. It was a 30-gene hereditary cancer panel done by Color Genetics. They returned ancestry and a few fun facts. Our real goal here is to figure out what happens when you reduce all these barriers. You don't have to know your family history. It doesn't have to be a complete family history. Cost isn't a problem. Do patients do it? Do physicians do it? This is the workflow that we used. You can see that we got rid of the paper form. We wanted to make this all online because that's scalable. We can do that across the system. So educational video, consent, all of that captured on our online portal. Physician places the order with a BPA that says, hey, your patient wants to do this. You go to the lab, get it done, work with Color. And here's the most important part. We have 6 genetic counselors. We're talking about doing genetic testing on 10,000 patients. Those 6 genetic counselors don't have enough hours of the day to see all the positives that are going to come back. So we use Color Genomics for genetic counseling support. So they are the initial genetic counseling follow-up for all of our positives. They talk to our patients and then refer them back to the North Shore clinic that needs to see the patient for the additional screening that they're going to need. So this really is a partnership. We work together to make this happen, integrated heavily into the EHR and into the patient portal. So what did we find out? Well, we offered about 35,000 patients the test to get to the 1,000 to say yes. Pretty good read rate, somewhere around 80%. We had to place about 1,200 orders to get 1,000 tests, way better than the rate that we had with pharmacogenomics. Again, this is a blood draw. The patient would go there right after their physical to get their annual labs drawn anyway. We have identified that some percentage of patients are actually now getting their labs done before their annual physical, and that might represent these 200 that didn't get tested. We only found about an 8% pathogenic variant rate, so that's a big drop off from that family history tool, but what you kind of would expect. And about 40% of the patients did get a specialty referral based off of their positive result. And 25% of the positives that we had would not have met criteria based off the GWA or that family history tool. So we're identifying undiscovered risk. So this sets up a world where you've got to take the two approaches and merge them together to come up with the best possible approach to personalized medicine in your healthcare system. And we're working on that right now. For those of you who are geneticists or interested in genetics, here are variants that we found for this particular population, kind of just the things that you would expect. Some things are more clinically important than others. It's probably why you saw the differences in the referral rates as well. All right, so we could do 1,000 patients. We did it in 2 months, 4 sites. That's not across the healthcare system. Let's build upon that and expand. So we did the DNA 10K. So in April we started, we said, let's do 9 months, 10,000 patients, 15 sites. We're gonna offer cancer, cardiovascular risk, pharmacogenomics, and fund traits. So again, do a small pilot, learn your lessons, and then grow that. Do a small pilot, learn your lessons, and grow that. We just kind of stack on top of each other. Now that we have 10,000 patients, we can start thinking about clinical interventions and looking at downstreams associated with that. We can also talk about and market on a large scale differentiating care experience, because now we're starting to hit a big enough population that you can actively go out in the market and you can talk to patients about how their care is going to be different in our healthcare setting. We're going to look at the financials associated with it, and then we've talked about brand recognition. And we believe that patients might select providers based on this offering because we had the earlier signal that they felt like their care was significantly better when they had genomics. So we're looking into that right now. So here's early data. Started in April. It's October 4th right now. We have over 8,000 patients consented. So we didn't hit the 10,000 patient mark that we wanted to at this point in time, but we're getting closer. There's a strong interest. More than a quarter of our patients have enrolled. So we offer the test, and 28% of patients agree to do the test. 50% are more likely to follow the screening recommendations from their provider. So this is building off that pharmacogenomic data that says you can engage patients and get them to do things differently. And because of the genetics, we were curious, will they talk to their family members about it? And about 3/4 of them will. So that's great. MD engagement. Most of our MDs have at least ordered one test. So we've kind of gotten them energized about it. It's not like there are 2 or 3 MDs driving this whole thing. We're beginning to do this across the healthcare system. 81% of the physicians believe that this is differentiating to their care compared to the average primary care visit. So it's, again, that branding thing, that thing that we really are trying to do, differentiate the care experience using personalized medicine. For clinical outcomes, we talked about the positive rates. Most patients have an actionable pharmacogenomic variant. When I say most patients, it's 99%. The virtue of the selection of genes they decided to cover. And we're getting this data back into Epic, so it's discrete and we can fire things off of it. That's all great, but I don't want to say that this is a perfect world. We think about the baseline and where people are in the process. Even though we're getting close to our 10,000 goal, 40% of our patients aren't telling us whether they want to do this or not. They're not acting upon it. About half the population, we've got to figure out a new way to engage them and get them involved. 20% are just outright declining the genetic test. We've got to understand why they're doing that. And then even once you say you want to do it, there's a whole number of places in the workflow that you can fall into and fail and not complete it. But for those 5,000 patients who've completed the process, of the 8,000 that have consented, what do their demographics look like? Well, it's middle-aged people. Not surprised there. The ethnic breakdown, it matches our population pretty well. I will say that we're undersampling in the African American population. We've got to begin to understand that. Other than that, it matches kind of our demographics as to be expected. So those are the demographic data. The clinical demographic data gets me even more exciting. So these patients are not necessarily healthy patients. The 3 leading comorbidities: hypertension, obesity, and depression. And now that we have pharmacogenomics in there, the depression becomes really, really interesting. We talked about patients being in different steps in the process. And so we were looking at, is there a clinical picture that predicts whether you're going to complete the process or not? We haven't finished that analysis, but an early assessment is you're more likely to complete the blood draw for the genetic test. If you do that, you're more likely to have more comorbidities than if you don't answer or read the message at all. So that non-responder group, they're typically healthier. Not really surprising, but it was nice to get confirmation there. So we've got to figure out a new way to engage them in their healthcare. How do we keep them well? Can we teach them about wellness and staying that way? Maybe. We're going to go after that and see what that looks like in the next year. Again, we're closing the loop with providers. We're giving them real-time data for themselves and how their patients are doing so that they can begin to understand how this process is impacting their care. So for this particular doctor, 15% of the patients that he's testing have positive genetic results. It's pretty interesting to them, especially when you come down to the system rate and you get 10% or 9%. It depends on how you round. And then we continue to tell them where we are. We also use this moment to do some education. We give them a patient story that came through this, and then we link that patient story to some fun fact about the genetics. And we did that here. And then we always tell them how to get more information, who to talk to if they have more questions. We want to give them a next step every time we're talking to them. Here are the genetic variations we're seeing here. It's basically a mirror image of the DNA 1K, which is to be expected. So what are our challenges? Continuing to be education, new and novel educational mechanisms and resources. We've got to improve the patient and clinician follow through for the recommendations. So we're identifying patients that have risk. You saw in the one study that only 50% of them were following up with that. How do we close that? How do we get that to 80 or 90%? And then we've talked about doing this in 15 sites. The first slide I had, we had over 100. How do we close that gap? What does that look like? What does that education look like? That's really what we're focused on right now. And we're at the point where we're getting stakeholder engagement, kind of starting from the beginning. So next steps, population screening and family history together, updating the system. We have VUSs now. When those change to pathogenic, how do we update? How do we recontact the patient? Some problems that some groups were discussing yesterday. How do we continue to lever outside resources like the genetic counselors? What does that look like? What do risk scores look like? Kind of talked about that. And then once we solve DNA, then comes all the other omics. Some people in the back are smiling because RNA is going to become really important. The microbiome is going to become incredibly important. And any other omic that I haven't thought about today, those will become important too. How do we learn from these lessons, apply those, bring those things to improve our patients' lives? Conclusion, you can do it. Takes time. You're going to get it wrong. You're going to make it better. We believe digital engagement's key. Bringing healthcare patients outside of the walls of your healthcare system. You're trying to change patient behaviors. And collaboration is must to get this done. So thanks for your attention, and I'll take a few questions.
All right, I think we have time for maybe 2 questions. You'll get him later.
Just a quick question, Mark.
No, I'll bring you. We've got people online, so I'll have to use the mic.
Thanks, Mark. Again, a very interesting presentation. Just a quick question about your, I'm going to forget it, genetic wellness assessment test, and even the follow-up procedure that you described there in terms of depicting basically the population that said, yes, I'll do this, or that actually responded to it. I wasn't sure of the response rate for the GWA, but more importantly, did the profile of the conditions for which you described individuals that participated in the latter test, did that match basically what we see, or is there, so for, 30% of the population has hypertension, dyslipidemia, and so on and so forth. Was that different in the profile of those that participated in the test, the latter test?
Yeah, so you asked kind of two different questions
Yeah, I did.
there. So in our primary care setting, are hypertension, obesity, and depression, regardless of where you are, the most common comorbidities? Yes. So they're the same problems, but they're more likely to have other additional problems. And know that the top third is always the same, the bottom third is always the same, but the percentages are just a little bit higher. So there's not unique problems, and that's using the Elixhauser model for categorizing these patients, and that's a predictive model for inpatient readmission or admission to the hospital. Works out really well. We did that for another project, so we took that to understand the comorbidities. And then for the GWA, what was the like completion rate? Like
Right.
how many
per year, realizing that they could do it the next year, they could do it the next year. I mean, ultimately, after X number of years, did
So we didn't see any attrition in that capacity,
okay.
but the one place where we did see attrition is when we had the paper in the office and the online, we were up around like 90% of patients completing it.
Oh, that's fine. Good.
When you get rid of the paper, you're dropping down to around 40%. But we did that because physicians were really frustrated with the amount of time it was taking to do the paper, and it was making them delayed. So, don't let perfection get in the way of progress. Yep.
Mark, thanks for that great talk. Quick question about that testing the population. Based on, I can see the value of it for the branding of the institution, but for that 9% rate, I mean, right now you're collaborating with a company who does that free genetic, assuming free, well, at least not from your side. Is this something that's expandable in the long term for a healthcare system with that rate? I mean, one thing I found really encouraging is for pharmacogenomic, you're hitting 99%. So that's really a good number to push for any institution to start that test. But for disease risk, is this something that could be sustainable for the long term?
Yeah, so we're in the middle of answering that question right now. We're collecting the clinical data downstream to say, here's what the patients are doing. Does that matter? At North Shore, we're using this as a brand differentiator. And so at some point, I may not care about your genetics as long as you get your knee replacement done at my institution, you get your hip replacement done. Can we bring new patients in there? But we know that just population screening and offering that to people is not going to meet everybody's needs. There are going to be people who can benefit from genomic testing that are going to say no to a population screening. How do you identify those people, and how do you get them the genetic test that's going to help you understand their process a little bit better, which is why we're trying to merge the family history with that population screening to find the right mix. You might imagine there's individuals who say no to a population screening, and then when they answer the GWA, the family history tool, and they start to piece together that my mom had breast cancer, her sister had breast cancer, and somebody else died of pancreatic cancer, well, maybe now I want to be tested because that's indicative of a BRCA1, BRCA2 variant, right? So how do we motivate patients to do things differently with this new data that we have? It's a huge challenge, and it's really exciting to work on, and look forward to the future. So hopefully I can come back and tell you, yeah, it's financially viable. You should just blanketly test everybody, and it works really, really well. I don't know. We'll see.
Okay, we're going to have to leave it at that. So Dr. Dunnenberger will be down here for a few more minutes. So if anybody has questions, please just come down to the front. Thank you